كيفك باسم؟
هاي أحمد، الحمد لله. أنت كيفك؟
الحمد لله good busy day man.
شفت على جوال قال امبارح بالميتنج بدبي.
Yes, bumped into her and I was back in Abu Dhabi at 1 in the morning so
يعطيك العافية.
so everything is still backwards time and sleep deprived so
I know.
we're living on caffeine, alhamdulillah.
So yeah, we are good to go at your mark.
So who's going first, by the way, me or you?
لا I'm gonna go first and then the cases بعدين.
Okay. خلاص then.
So good morning, good afternoon, good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the second multiple sclerosis virtual clinic, our one-of-a-kind learning experience. During this educational activity, our top-notch MS expert will share with you real-world clinical cases. Therefore, I would like to invite you to interactively participate by analyzing the cases shared and by sharing your clinical opinions in the chat box, as your participation will definitely make it a fruitful meeting. This webinar of today is very special because first, it is happening on the World MS Day, the day during which we should all raise our voice to boost awareness about the disease, share experiences, and improve patient support systems so we can elevate the MS care to an even higher level, especially in our Middle East and North Africa region. Second, it is special because we are hosting two top-notch MS experts, Professor Yamut and Shatila. And third, it is special because of its topic. We will review and compare the treatment paradigms of the escalation and early aggressive approaches to treatment of MS. Before starting, let me thank Novartis for sponsoring this educational activity. In our first session, Professor Bassem Yamut will discuss the existing treatment approaches for the management of MS with emphasis on the induction strategy and the optimal time for disease-modifying therapies escalation. Professor Yamut is currently professor of neurology at the American University of He was a professor of neurology at the American University of Beirut Medical Center, and he is currently the director of the Neurology Institute at Harley Street Medical Center and MS Center in Abu Dhabi. He received his training in neurology at the University of Cincinnati, Ohio, followed by a fellowship at the Montreal Neurological Institute at McGill University. He is also head of clinical research at the Multiple Sclerosis Center. He is currently the president of Menactrum, fellow of the American Academy of Neurology, and member of the MSIF International Scientific Advisory Board and multiple regional and international multiple sclerosis advisory boards. Professor Yamut is one of the leading experts on multiple sclerosis in the MENA region, with recent research on epidemiology, quality of life of patients in the Middle East, treatment, novel therapies such as stem cells and venous stenosis, and the impact of wars on MS. In addition, he is the principal investigator on several ongoing international multiple sclerosis trials. Professor Yamut has authored many research and review papers and is currently the chief editor of the MS newsletter MS Today and on the editorial board of the Multiple Sclerosis and Related Disorder and Pediatric Neurology. Professor Yamut, we are always honored to have you as a speaker with us. Welcome, and the floor is yours.
Thank you very much, Maya, for this nice introduction. Thank you for Novartis and for IVPN for hosting me today to give this presentation. So I will share my screen. Okay. So the topic I will be addressing today is the issue of starting treatment aggressively from the beginning or starting with moderate efficacy medication and then going into escalation. Should we hit hard from the beginning or should we wait? These are my disclosures. As I always say, we've been doing very well with the treatment of MS. We really changed the natural history of the disease over the last 20, 25 years. In this study from the single Italian center, they looked at their patient in their 80s and 90s, how they were doing, and then compared them to their more recent patient in 2011. So from the period of no treatments to the period now of very high efficacy therapies. And if you look here, this is the probability of reaching EDSS-6 disability, which means inability to walk independently, having to use a cane. And this is the age of the patient. So if you look at the 80s and 90s before any treatment, at the age of 50, we can see almost 30% of the patient were on a cane already. They are not able to walk independently. Then came the interferon and the number improved. And we can see here around 2000, we're down to around 20%. And now with the very high efficacy medication, we're down to around only 5% of patients at age 50 being unable to walk independently. So we came a very long way with the MS treatment, and we actually did very well by changing the whole history, natural history of the disease. And now many of our patients are living a very long life with minimal disability. So the question is, how did we achieve this? Let's go back to the basic pathoimmunogenesis of MS. Now, MS, as you know, is an immune-mediated disorder with the lymphocyte invading the central nervous system, activating many other cells, macrophages, microglia, secreting detrimental cytokines, and ultimately producing demyelination. And then when demyelination is quite advanced, ultimately we can see that there is some axonal loss. It's not showing in here, but ultimately there is axonal loss. And axonal loss correlates with irreversible disability because you cannot regenerate axons in the central nervous system. However, myelin destruction can be repaired, and remyelination occurs usually within 4 to 6 weeks, which is the time of recovery of a relapse. So axonal loss correlates with ultimately the disability. Now, when we went back and looked at all the pathology of MS, it turned out that most of this axonal loss occurs very early on during the acute inflammatory lesions. And then when they looked at these inflammatory lesions, most of the axonal transection were actually in the actively inflamed lesions, while the old lesion where the inflammation is gone, we didn't see any axonal loss. So therefore, the way to prevent this axonal loss and therefore irreversible disability is to control inflammation very early on and therefore prevent the ultimate disability. So when we look at the patient and look basically at the relapses, for every single relapse we see, which for us is a disease activity and therefore is inflammation, actually there are 10 new MRI lesions that are occurring in the brain, and all of them are inflammatory and destructive. So if you look at any brain MRI, out of 10 new MRI lesions, only one will produce symptoms. Even when we look at the normal white matter of the brain, not the lesion, we can see ongoing inflammation in the normal white matters with axonal loss. So the clinical picture of the patient is only the tip of the iceberg, and below it, there are much more inflammatory activity ongoing and much more axonal loss. So we have to keep all of that in mind, basically. Now, the question is, how does the brain recover if axonal loss is irreversible? How does a patient, for example, who has sudden paralysis of the hand, then recovers? And the answer is neuroplasticity, because the brain works in a way that if a certain area of function is lost, other areas of the brain will take over. And this is an example of a healthy control. This is a functional MRI. This patient is activating his right hand, and we can see the activity in the left motor cortex and over here. And this is an MS patient that had multiple attacks, including right upper extremity weakness, but has recovered fully. And now whenever he activates his right hand, we can see a large area of the brain is activating, extending even to the temporal lobe. And this is really neuroplasticity. So the brain is using its reserve to really take care of the lost function. The problem with this is that if the axonal loss continues for a very long time, then you are going to exhaust your brain reserve. And then comes a point where every single new lesion or axonal loss will produce disability that cannot be compensated anymore. And this is probably why after 10 to 15 years of repeated relapses in RRMS, we end up with a progressive phase, probably at a point when the neural reserve has been exhausted. So this has also been shown clinically. This study from Wenchaker has shown that the patients that have a high number of relapses during the first 2 years of the disease are the ones that will get most disability ultimately. So if you have one relapse during the first 2 years of your illness, it takes you around 20 years on average to reach an EDSS of 6 or basically disability. But if you had 5 attacks during those first 2 years, it only takes 6 to 7 years to reach EDSS 6 or walking on a cane. So basically, again, showing that early high inflammatory activity is indicative ultimately of disability in the future. This has also been shown by MRI. This is basically the Queen Square study showing that from the first brain MRI a patient does in the clinic at presentation, if he or she have more than 10 lesions, then 20 years later, 45% of those patients will be on a cane. While the patient that on their initial MRI had very low lesion load and therefore a very low inflammatory load, 1 to 3 lesions, at 20 years, only 18% will be on a cane. So almost half just by the MRI load. So based on all of that, the pathology, the clinical and the radiological picture, it's clear that the aim of every single treatment MS is to stop this inflammation early on. So we have to stop all relapses, we have to stop all new lesion on the brain MRI. And this, I think, is the major principle of treatment in MS currently. Stop all inflammatory disease. So there were 2 ways of approaching treatment. The traditional way, which is the escalation therapy, which will be starting with moderate efficacy medications, and then we'll switch to higher efficacy in case there is evidence of ongoing activity. The rationale is these low efficacy medication or moderate efficacy medication are very safe, and therefore we are betting on their safety and hoping that this medication will control the disease. And the key factor is really identifying those patients that will have probably a rather mild disease of the mild course of the disease. And the second key factor is that we should immediately escalate treatment if there is any evidence of disease activity. Now, the second rationale is basically starting high efficacy treatment from the beginning. And of course, the rationale is that you will hit inflammation very early on with very high efficacy medication, stop all inflammation, stop all axonal loss, prevent disability in the future. The main thing is to identify those patients that are at high risk of a very aggressive course, because the problem is the higher the efficacy of the medication and the higher their immunosuppressant effect, the lower is their safety. So we have to balance those 2 things. So let's speak about those 2 approaches. The case for early aggressive therapy. So if you start using highly aggressive, high efficacy medication from the beginning, this is what you're going to see. Basically, complete suppression of inflammatory activity. This is the alemtuzumab from the CARE-MS1 trial, where they used alemtuzumab from the beginning in treatment-naive patient. And as we can see, over 8 years, complete suppression of relapses, almost no relapses, close to 0. Same if we look at natalizumab. Again, this is from the top trial of natalizumab. And this is the high relapse rate initially. And on natalizumab over 10 years, almost complete suppression of all relapses, close to 0 over 10 years. Studies have also shown that the high efficacy medication ultimately will affect the disability outcome. This is the study from JAMA by Brown and his group, where they took cases from the MS base that were started on either low efficacy or high efficacy medication from the beginning. And after an average of 9 years here, we can see that significantly higher number of patients on the moderate efficacy medications, in this case, interferon glutamate acetate, a higher number went into secondary progressive MS, as compared to a lower number of patients converting to SPMS that were on the high efficacy medication, and mainly the monoclonal antibodies, alemtuzumab, natalizumab. And if we look here at the hazard ratio, there was a 44% decrease in the risk of converting to SPMS by being on high efficacy medications from the beginning. Another study, which was very interesting, that compared the Swedish registry to the Danish registry from Denmark. And apparently in Denmark, they always start with moderate efficacy medication, mostly teriflunomide. So 92% of the Danish registry patients started on low efficacy or moderate efficacy medication. While in Sweden, they are more aggressive in starting early high efficacy medication, and specifically rituximab, which is used widely in Sweden. So in the Swedish registry, actually only 65% of patients started on the moderate efficacy medication, while almost 1/3 were already started on the high efficacy medication, as compared to only around 7% of patients in the Danish registry. So when they followed those two patients over 6 years, those two patient cohorts over 6 years, we can see that disability progression was much more advanced in the Danish registry as compared to the Swedish. And even the number of relapses were much higher in the Danish registry comparing to the Swedish, meaning that early initiation of high efficacy medication ultimately is preventing the disability accumulation on the long term. And of course, the highest efficacy treatment we have nowadays in MS is really the hematopoietic stem cell transplantation, whereby you basically transplant the whole hematopoietic part of the bone marrow and produce a new bone marrow that is more autotolerant and less autoreactive. And of course, this is a complicated procedure with high morbidity and even mortality, actually. But look at the results. These are the patient. This time 0 is the hematopoietic transplantation. The red triangles are the number of relapses in every patient before and after. And if you can see, very highly active disease in all of those patients. And after transplantation, almost 0 relapses for up to 10 years. The same for the MRI. All the triangle are MRI activity. After transplantation, 0 MRI activity up to 10 years. So almost complete suppression of the disease. And actually, hematopoietic stem cell transplantation was able to achieve the highest NIDA level that we have so far. NIDA meaning no evidence of disease activity, meaning no relapses, no disability, and no new MRI lesion. And if you look at the NIDA number, our best disease-modifying therapy achieved a NIDA here between 40 and 50% at 2 years, compared to almost 80% at 2 years with the hematopoietic stem cell transplantation. And look at it here, after 5 years, most of them dropped to around 20% NIDA, while stem cell transplantation maintained a NIDA of almost 60 to 70% at 5 years. So we can definitely, with high efficacy medication, suppress inflammation very early, have a very good outcome in the future about disability, preventing disability. So what's the catch in here? The other, to complicate the picture more, actually, enter the concept of PIRA. PIRA is progression independent of relaxed activity. We used to think before, and that was the new catch now, that after every relapse, the disability that's remaining from the relapse is really the disability of the patient. But then during the OPERA trials with ocrelizumab, they found out that patients without any relapses actually are having progressive disability. So as if there is a silent disability that is progressing irrespective of relapses, called PIRA. And actually, when they measured in the OPERA trial the disability progression, most of the disability progression was actually PIRA, not due to the relapses. Almost 80% of the progression of disability was due to PIRA, not to the relapses. The good point is, when we looked at the ocrelizumab arm and the interferon arm in the PIRA, it turned out that ocrelizumab was able to suppress both PIRA and the relapse-related disability. So both of them were decreased on ocrelizumab compared to interferon beta. So even against the PIRA, or the silent progression of disability that we are not seeing between relapses, even there, high efficacy medication are more effective than moderate efficacy medication. So why don't we always use then these high efficacy medication from the beginning? It's really the safety. And it's clear by now that if you plot safety against efficacy, the higher the efficacy of these, sorry, this is not showing well, the higher the efficacy of the medications, the lower their safety. And as we go higher, for example, to alemtuzumab, we have autoimmune disorder. With natalizumab, we have PML. With autologous hematopoietic stem cell transplantation, we have a lot of severe infection and even mortality. So at that point in time, a decision has to be taken. You have to choose the right patient that you think is predictive of a rather mild course and go maybe with the escalation therapy. And then look at the patient that seem to have a very aggressive course based on the factors I will talk about right now, and then start in there with the high efficacy medication, and that will help him in the future preventing disability. So balancing efficacy and safety is the main issue in the decision to be taken. And as I mentioned, the most important thing is to select the right patient. Now, why do we use then escalation? It's clear by now that there is a certain group of MS patients that follow a very mild disease course. And I'm sure you've all seen those patients after 20 years still doing very well on minimal treatment. So a certain number of patients will do well. And in those patients, probably using moderate efficacy medication that will be able to control their inflammatory activity without the safety problem, then it would be ideal. If you look here at the Champions trial, which was the trial of interferon beta-1 back in the late 90s, they enrolled 383 patients. At the end of the trial, of course, many patients dropped out, but what remained, we had 122 patients that still had very minimal disability, EDSS 2.5 or less. So let's say all the other patients did bad. It's 122, meaning that after 10 years, 1/3 of the patients just being treated with simple interferon were still doing well with minimal disability. So there is a proportion of patients that will follow this mild course. This is the Mayo Clinic study where they looked at their patient in 1991, and they selected the patient that had an EDSS of 2 or less after 10 years from disease onset. Then they followed them for another 10 years. They had 28 patients. And in 2001, out of the 28, 25 were still doing very well. Very well meaning no SPMS conversion, no disability. They were still employed and they had a normal cognitive function. So all the aspects of the disease were assessed and the patients were still doing very well. Again, this is the study from the Canadian-Italian study where they did the same thing. They looked at patients at 10 years and selected the patient that still had a low EDS at 10, let's say 2 or less or 1 or less, and then looked at them 10 years later. And the one that had EDSS 2 or less at 10 years, at 20 years, 80% of them still had a very low EDSS. And those that had an EDSS of 1 or less at 10 years, at 20 years, 80% of them had still very low disability. And remember, 70% of those patients were mostly being treated with interferon. So there is a certain proportion of patients, we don't know how much, is it 20, 25, 30%, that will follow a mild course. And if we are able to pick them up early, we might benefit them, but not by not giving them high efficacy medication with immunosuppression and adverse event. So, but if you're going to go with the escalation issues, the main point is really to keep an eye on those patients. MRI and clinical exam should be done every 6 to 12 months because we have to detect an early signs of treatment failure, which means new relapses or new lesions, which mean these are not patients that are following this mild course, and therefore escalation should be done early. And any time lost with inflammatory activity ongoing without escalating is axonal loss and therefore a probable future disability. Now, how do we assess escalation? Of course, we have many, many guidelines to tell us when we should escalate the treatment. The Rio score, for example, based on whether relapses are occurring or new lesions are occurring. We have the Minectrim guidelines, again, based on clinical disease activity and radiological activity. The AN guidelines, again, based on radiological activity and relapses. So basically, if you have a new MRI lesion or a relapse, the patient should be escalated and the drug should be considered not sufficient to control the inflammatory activity. So since the major thing is to predict which course will this patient follow, the question is, can we predict this course early on? And the answer, yes. There has been many studies that showed that there are certain predictive factors early on from the presentation of the patient that can help you take this decision. This is the Confavre trial showing that poor recovery from the first relapse is a poor prognostic indicator. A high number of relapses in the first 2 years is also a bad prognostic indicator. I already showed the Queen Square study showing that a high lesion load on the MRI initially is a bad prognostic indicator. This is the CIS cohort from Barcelona, the largest CIS cohort in the literature. And again, they showed that the clinical presentation, optic neuritis, younger age are good prognostic factor. Presence of oligoclonal band is a negative prognostic factor. A high lesion load on MRI, 10 lesion or more, is again a bad prognostic factor. So if we put all of these things, we have clinical factors, parameters, we have MRI parameters, and we have CSF markers. So if we put all of these factors together, we are able to a good extent to predict the course of the patient and therefore make a scientific or an evidence-based decision about whether to go with high efficacy from the beginning or try moderate efficacy and give the patient the benefit of the diet with the safety. And of course, we recently are going to be adding the neurofilament light chain, which is also a serum biomarker for disease activity and severity. If you look, for example, at the 2021 ECTRIM guidelines, they of course recommend using any of the medications during the early disease, but again, they stress, consider choosing a higher efficacy disease-modifying drug early on according to disease activity. So your choice should be based on the disease activity. And if we look at our MENACTRIM guidelines, again, we divided the patient into 3 categories. The moderately active disease, which means the patient that have all the good prognostic factor, so low rate of relapses, probably optic nerve or sensory symptoms, not cerebellar and motor, young age, female, low lesion load on the MRI, complete recovery from the relapse. If they have all these good prognostic factor, we can still go with the moderate efficacy medication like interferon, glatiramer acetate, teriflunomide, or dimethylfumarate, or even fingolimod. If the patient is highly active, which means he or she have more of the bad prognostic factor, then we should start with higher efficacy medication, the S1P receptor modulator, cladribine, natalizumab, ocrelizumab. And if the patient have very rapidly evolving aggressive disease, and this was defined in the literature and in our MENACTRIM guidelines as basically a first-year disabling course, which means at least 2 relapses that were predominantly motor and cerebellar, that were disabling and did not recover fully with a very high lesion load. If we have all these bad prognostic signs, then this is a rapidly evolving aggressive MS. And our recommendation is to go immediately with the highest efficacy medication, which are the monoclonal antibodies. And of course, at whatever level, especially if you're using moderate efficacy medication, you should follow the response of the patient every 6 to 12 months. And in case of non-control of the inflammatory disease, meaning relapses or new MRI lesion, you should immediately escalate to the high efficacy medications. So I want to add one more thing, because this approach is changing a little bit the last 2 or 3 years. And the reason why this is changing is because the safety efficacy balance is now shifting toward efficacy, better efficacy, and better safety. And the reason is that we have now new DMTs that are highly efficacious with a very good safety profile. And for example, are the B-cell depleting therapies or cladribine. And on the other hand, we also have now new method to mitigate the adverse event of certain medications. And for example, with natalizumab, now we have data showing that an extended interval dosing of natalizumab every 6 weeks instead of every 4 weeks does decrease significantly the risk of PML. So now with this new kind of armamentarium that we are having with the high efficacy DMTs, we are probably shifting more and more toward using high efficacy medication much earlier and much more than used to do before. So I just wanted to mention that point, that is really changing our approach a little bit for the last approximately 2 or 3 years. So in conclusion, the end result is really personalized medicine. So you have from the beginning to choose the right treatment for the right patient and at the right time. The right patient, meaning you look at their prognostic factor that I mentioned, CSF, MRI, clinical, and decide if the patient has good prognostic factor or not. If not, then you have to go, depending on that, you decide whether to go moderate efficacy or higher efficacy treatment from the beginning. The right time is as early as possible. And in case the patient is having continuous disease activity on moderate efficacy medication, immediately escalating to a higher efficacy medication. So this kind of personalized medicine will ultimately benefit our patient. And this is how we are achieving this very good result with MS treatment, as I showed in my first slide, with a significant decrease in disability progression in our patients. Thank you very much. And of course, you're all invited to attend our next Minactrims Congress in Cairo next November. And if anyone needs an invitation to their Minactrim, we'll be more than glad to invite you. Just contact Maya and she will arrange everything for you. Back to you, Maya.
Thank you, Professor Yamoud, for, as usual, a very enriching and comprehensive presentation. And please allow me to take some questions.
Sure.
So the first question, if we start a patient on a high disease modifying drug, can we de-escalate back to a moderate, for example, efficacy? If a patient was started, for example, an anti-CD20 monoclonal antibody, can for some reason go back, for example, to fingolimod or siponimod?
I don't think there is any need for de-escalation. And from all what I've showed about the pathology of MS and the need to control the inflammation very early on, once the decision has been taken to start a high efficacy medication, it means the patient needs it. Either he or she have the bad prognostic factor, or this patient failed on a moderate efficacy medication and needed escalation. In both cases, we cannot de-escalate because this is not a patient out of this 25 to 30% that are going to follow a mild course. This is a patient from the remaining 2/3, and therefore we have to control the inflammatory disease activity for a very long time without any de-escalation. In case we need to switch the treatment because the patient develops side effect, or let's say a positive JC virus on natalizumab or whatever, then I would shift to another high efficacy medication and not de-escalate.
The second question, what is the data or the current data or recommendation for stopping disease-modifying therapy in MS?
Yeah, that's a very good question, and a question to which we don't have a final answer, but we have an idea. Now, it has been shown that most of the inflammatory activity in MS occurs early in the disease. And actually, if you take the relapse rate, it decreases significantly with time. And it decreases even significantly more with age. So above 50, you have a significant decrease in number of relapses and number of new enhancing lesions. So this is what you call immunosenescence, or the immune system growing old. So the question, if you have a patient above 55 or 60 that has been very well controlled on treatment for a very long time, and we know there is not much inflammation, can we stop the treatment? The other question is younger patients that are in their 30s, let's say, and have been very well controlled for 5 to 6 years. Can we stop the treatment? Now, for the younger patient, most of the studies have shown, because they still have a very active immune system, if you stop the treatment, there is a very high chance of recurrence of the relapses and the disease activity. So I wouldn't stop it. Now, in patients above 50 that have been controlled for a very long time, 5 to 10 years, it's probably more likely to stop the treatment and follow the patient closely, of course. And there we have a higher chance of not running into disease reactivation. Now, the final answer to this question is going to come within the next 2 to 3 years, because there are ongoing now 2 or 3 large clinical trials addressing exactly that question, which means stopping treatment in patients after at least 5 years of disease control, and especially in patients that are older than 50. So these trials, I think, will give us the answer. But if you ask my personal opinion, patients above 50 or above 55 that have been well controlled for at least 5 years, and I know that at that age, with the higher morbidities, diabetes, cardiac disease, hypertension, we will have a higher risk and lower safety profile with our immunosuppressive medication. The balance there might go towards stopping the treatment and watching the patient very closely for any reactivation.
Another question for the high efficacy treatment that are low frequency medication like cladribine and alemtuzumab and that are taken for just few years. What if a patient develop disease activity after these 2 years of cladribine or alemtuzumab? What would be the treatment strategy?
Yeah. Now, for alemtuzumab, it's clear, I think. The study has shown that patients that develop the new disease activity in year 4, 5, or up to 10, a third course of alemtuzumab was quite effective in controlling the disease. And then when they followed those patients from the CARE MS1 and CARE MS2 that received the third cycle, and they followed them in the TOPAZ trial up to 9 years, they did very well. Now, for cladribine, we still don't have such a long follow-up data. And actually, we just had a committee meeting for the last 3 months. I'm chairing that committee to answer that question. You know, in case you have cladribine, patient on cladribine having a new relapses beyond year 4, what do we do? The consensus is the following. If you have relapses on cladribine in year 3 and 4, which means they did not finish the full 4 years, you can go either way. You can either use a third cladribine cycle, and this has been used in many patients and many of the series that we reviewed over the last 2 months in Europe, or you can shift to another disease-modifying therapy. It's your decision. In case the disease activity is fully controlled for the full 4 years, which is the course of cladribine, and the patient develop any disease activity beyond 4 years, our only Lebanese cohort and the Italian cohort, and more recently the German cohorts have shown all that at least 50% of the patients that the patient that do well on cladribine the first 4 years should be considered as cladribine responders. And just like with alemtuzumab, if you get a disease reactivation beyond 4 years, then it's probably a good idea to give then a third cladribine dose, just like we did with alemtuzumab. So this would be the approach of how to manage patients that relapse on immune reconstitution therapies.
Another question about anti-CD20 monoclonal antibody. If there is any data or guideline or recommendation to administer immunoglobulin with the administration of scheduled dose of immunoglobulin with the administration of anti-CD20 monoclonal antibody to prevent infection or side effects?
Yeah. So, as you know, with chronic anti-CD20 therapy, which are B-cell depleting therapy, we might develop hypogammaglobulinemia. This is not something that occurs early. It usually occurs beyond 4 or 5 years and even longer, and over chronic treatment. And the main issue with the infection is if there is a lower IgG. IgM doesn't make a big difference with infection, but a lower IgG. Now, we have really relied on the literature from our rheumatology colleagues, where they have used rituximab for a very long time. And their recommendation when we discuss this issue with them is that they never use immunoglobulin or IVIG replacement, even in patients with very low IgG, unless there is evidence of clinical infections. So a simple hypogammaglobulinemia without clinical infection, there is no need to replace the gamma globulin with IVIG. But in case they have a case of hypogammaglobulinemia with evidence of recurrent infection, then yes, at that point in time, I would use IVIG to replenish. And remember, this is a late complication with the chronic use of the B-cell depleting therapies.
And a final question, you talked, Professor Yamut, about personalized dosing for monoclonal antibody. So for the 3 anti-CD20 drugs used in MS, rituximab, ofatumumab, and ocrelizumab, for all 3, can we perform a monthly CD19 and dose these monoclonal antibody accordingly, or it is only applicable for ocrelizumab and rituximab?
Now, it's not applicable for ofatumumab, obviously, because ofatumumab is taken on a monthly basis. And ofatumumab produces a complete B-cell suppression because of the monthly use. So there is never any recovery of the B-cell. Now, for ocrelizumab and rituximab, yes, we can do a CD20 when the infusion time comes, which at 6 months. And in our center, what we have been using and are still using, that if there is no B-cell recovery, which means a CD19 count below 1%, this is the level that most centers would use around the world, then we delay the infusion another month or 2 months, and then we repeat the CD19. And as long as it's below 1%, so there is no B cell recovery, we delay the infusion until we get a certain recovery, then we give the infusion. We've been able to treat patients, let's say, with rituximab between 7 and up to 12 months interval between the infusion. And actually, this has been used during the COVID-19 infection because, as you know, there was a problem with coming to the hospital. So many patients actually, even in Europe, many MS centers started using this method, checking the CD19. And then whenever there was no recovery, actually delaying the ocrelizumab. And the studies came back from Europe showing that delaying the ocrelizumab dose up to 7-8 months even did not really affect the efficacy. So yes, you can do that. On one hand, you will allow to a longer interval from coming to the hospital, and probably this minor B cell recovery in between infusion might be helpful with on the long term with hypogammaglobulinemia and probably infection rates.
Thank you, Professor Yamout. I still have one final question. It's not directly related to our topic today, but if there is any data regarding the chickenpox vaccine with this monkeypox new infection for MS patients treated with disease-modifying therapies?
I'm not sure about that, but I think that the vaccine that is probably effective is actually the smallpox vaccine, which is a very, very old vaccine.
Old vaccine.
Yeah.
Thank you, Professor Yamout, for joining us tonight and for answering all our audience questions. So we will move to our second multiple sclerosis expert, Dr. Ahmad Shatila, also joining us all the way from Abu Dhabi. Dr. Ahmad Shatila is currently a senior consultant neurologist and head of the multiple sclerosis clinic at Mafra Hospital, Sheikh Shakhbout Medical City, Abu Dhabi, with over 12 years of experience in the field of neurology. He holds an American double board certification in adult neurology and neurophysiology. Dr. Shatila obtained his BS in biology from the Wayne State University in the US. He continued his medical education from the Medical College of Wayne State University. Dr. Shatila conducted his residency in neurology at the same Wayne State University and continued his fellowship in neurophysiology. Dr. Shatila's interests include inpatient neurology, including but not limited to stroke, IVTPA program development, status epilepticus. He is also interested in helping facilities develop a neurohospitalist model where the inpatient care can develop independently from the outpatient service. This includes a combination of patients, resident and nursing education, inpatient consulting services, and inpatient neurology services. Dr. Shatila had authored many neurology research papers with emphasis on multiple sclerosis and other neurological diseases. He is also a member of several regional and international neurology organizations. Professor Shatila will share with you real-world clinical cases for discussion. So I would like to encourage our esteemed attendees to actively participate in our case session and share with us your opinion as a clinician in the chat box. Dr. Shatila, you are the most welcome. Please start your presentation. Dr. Shatila, you are muted. Please unmute yourself.
There we go. Sorry about that.
Yeah, perfect. No.
Thank you. First of all, I'd like to thank everyone. Thank you very much, Maya, for the very kind introduction. I'd like to thank IVPN for the invitation today to come speak to you today. I'd like to thank Novartis for sponsoring this event, and I'd like to thank everyone for actually attending and listening to this lecture. So let me share my screen. Okay, just sharing. Now let me minimize all of these cameras. Move the tab bars a little bit. Okay. So first of all, I'm gonna give 3 clinical vignettes today. And as Maya said, the purpose of these is, first of all, definitely to raise awareness, ask questions, and I think one of the most interesting things about medicine, or the best things about medicine, it is an art. It's not always a science. Sometimes, we have a lot of data, and, Dr. Yamwood just presented a lot of data, but sometimes when you have the person right in front of you, you can look at the data and you look at the patient, and sometimes both of them don't exactly agree with each other, and what we would like to do or what the patient would like aren't always the same thing. So we try to find the best match in order to give the patient the best care possible. So please ask questions, and I don't think there is a right or wrong question, and there isn't a right or wrong way of practicing. It's just really what works best for your patient. So let me, okay. So case one. Okay, I gotta keep moving these tabs. Okay, so this is a 21-year-old female who presented at the neurology clinic back in February 2021. She presented for the first time. She has no past medical history. On December 2020, so about 3 months prior, she developed left eye pain, blurry vision, central scotoma, very indicative of an optic neuritis happening in the left eye. She went to a private hospital in Abu Dhabi, was diagnosed as optic neuritis. She was given 3 days of IV Solumentrol, then she was given a 9-day oral cortisone taper. Blood tests were unremarkable. She had an MRI in a private hospital, and it just showed 4 lesions. And then this was after the first hospital. She then went to another hospital. And this is not uncommon. A lot of our patients like going to different hospitals, and there's a lot of doctor shopping. So she had the first workup, went to another hospital. They saw the MRI. She had the lesions. She got some more steroids. And this sometimes is the unfortunate side effect of doctor shopping, that you can get concomitant care. You can get the same treatment twice. So she got steroids twice, actually, in less than a month. She has no numbness in her hands or feet. She has no unsteadiness, nothing suggesting ataxia. She's never had any episode of any neurologic problem lasting more than 24 hours. She's a non-smoker. She's a psychology student, and there's no family history of MS. So on physical exam, she performed, she got 34 out of 37 on the Ishihara plates. On that was the left eye, which she passed. She got 33 over 37 on the right eye, which suggests that there may be, and this was in the right eye, which is actually in the wrong eye, because she was complaining of left eye problem. So interesting enough, the eye that was symptomatic was normal. The eye that was asymptomatic was borderline abnormal, suggesting maybe there's some red color green desaturation. But I also felt this was most likely she was just getting tired, because I started with the bad eye first, and then when I went to the good eye, she got this borderline. But I didn't think it was really that she had color vision problem, because she had no APD, there was no afferent pupillary defect, she had no red desaturation, normal visual field. So I think she was just really tired. She did have a left eye node and intranuclear ophthalmoplegia, and her 25-foot walk was 5.91 seconds. So while, yes, her presenting symptom was optic neuritis, she actually was relatively slow when she walks. She's not exactly this fast sprinting 19-year-old you would expect to walk 25 foot and around 3.5, maximum 4 seconds. She's pushing up to almost 6. On her examination, motor exam is relatively normal, 5 out of 5. Reflexes, 2+ out of 5, and bilateral upper and lower extremities. Now, the interesting thing is her right plantar was upgoing, again, suggesting a corticospinal tract lesion. Again, suggesting that this isn't just right eye problem, and she's having more than what she's suggesting. Even though her initial symptom was visual loss in the left eye, I'm now showing you that she's slowed when she walks. She has upgoing toe on the right, suggesting a corticospinal tract lesion. She's slow and she has other problems. So this isn't just, one episode of optic neuritis and that's it. So when you look at the MRI, on the image on the left, you see one GAD enhancing lesion and run in the left hemisphere. And right next to it, there's this very small lesion that's also enhancing. Now you can consider this one bigger lesion, I'm just getting different cuts, or maybe 2 separate lesions. When you look at the axial images on the right, on coronal and axial, you see she has multiple lesions, periventricular, she has some juxtacortical. You can see some of the lesions are kind of clustered together, but she does have the regular stigma of MS. She's got periventricular, she has juxtacortical. I showed you on examination that she has infratentorial lesions going with the upgoing toes. She has the slowed gait, and she also has optic neuritis. So this is not, so these lesions in and of itself, while I don't show you the lesions, in the MRI actually of her spine was reported as normal. I don't have them with me because I didn't have those images, but they were reported as normal. But you know clinically there's something there. So now the question is, let's stop there. So now, what was the thought process on this patient? You know, hello? So,
Yeah, doctor.
okay. So I'm going to walk you through a little bit of my thought process. And again, like I said, I don't think there's a right, there's not a wrong, there's just what's right for that person who's sitting across the chair from, across the table from you. So now there's a couple of things. She's a psychology student. She doesn't want to come to the hospital. We know that she has motor, she has a motor deficit. And as Dr. Bassam just said, that's a bad prognostic indicator. People with motor deficits don't do as well 20 years later as the people with non-motor deficits. She did recover from her sensory problems, but she has a slowed gait as well, upgoing toes. Another thing is she doesn't want to come to the hospital, so they get infusions. She doesn't want to take injections either consisting of interferons. She doesn't want an oral tablet. She says, I'm not compliant. I usually take pills, my vitamins, my supplements, I'll take them for a month. And then the minute I feel better, I don't take my medicine. So again, long-term, compliance is going to be an issue. So then the question is, what would be a good choice for this person? And when I'm thinking about it, I'm like, okay, I could give her the first line therapies, but she was probably not going to take it. So did I really help her out? I could give her the infusions, but she doesn't want to come to the hospital every month for Tysabri or every 6 months for Ocrevus. Again, the issue is she says, I'm 19 years old. I don't want to be coming to the hospital. That's not really part of my lifestyle right now. So then, and she's definitely not an alemtuzumab candidate, and she's definitely nowhere near stem cell therapy. So, I discussed with her, we went back and forth, and I felt ofatumumab would be a good option for this patient, partly because long-term safety. We do know that ofatumumab, when we looked at the Asclepius trial, when it was compared against teriflunomide, even though I don't talk about this, we know that ofatumumab is more efficacious than teriflunomide, which again would be a good first-line therapy. So I'm not sacrificing efficacy. Safety, ofatumumab in my idea or my mind was the third generation, or it was the next treatment line in a long phase of B-cell depleting therapies, which started back in 1997 with rituximab. So this is not a medication that just came out on the market 3 months ago. This is a class of drugs that's been out for almost 25 years. I have experience with it. It's relatively safe. When you look at the Asclepius trial, the side effects of ofatumumab versus teriflunomide, they were very similar. So I wasn't sacrificing efficacy. I wasn't sacrificing safety, and I was giving this patient a lifestyle that she wanted. So we decided that we were going to go with ofatumumab. She got her first dose of ofatumumab back in March 2021. If you're familiar with ofatumumab, it's a monthly injection. It's given sub-Q, but on the first month, you need 3 injections. You get 1 injection on day 1, 1 injection on day 7, 1 injection on day 14, and 1 on day 28. After which you get 1 injection sub-Q, 20 milligrams every month. My nurse gave her, educated patient how to give it. Usually for the first month, we give it to her in person in clinic to the patient. And then we tell the patient, if you're doing good, you have no side effects, you can handle the first month, we'll give you 3 months prescription, you can take your injection at home. Again, going with her quality of life. We did an MRI at around 5 months later, just as a baseline, and it was repeated and it was stable with no change. And this was back in August 2021. We're now actually June 2022, and the patient is still on ofatumumab. She's still compliant, she's still stable, she's doing well, she's taking her medication, and she's and she hasn't had any relapses, had no further issues. So I guess in hindsight, 2020, in my mind, this was a good option because it met all the check boxes for what I thought would meet the best treatment algorithm for this patient so that I could control her disease, but at the same time, give this person the quality of life that she wanted. Now, I can go to the second case or we can open the questions. Maya, what would you prefer?
Yeah, let's go to the second case. We'll leave the question till the end.
Okay, perfect. Case number 2. This is also a 19-year-old female. So, as you know, MS is a predominantly young women disease. Predominantly, it's young women, reproductive age, average age of 27. So again, this is a 19-year-old female. She shows up in June 2021. On May 27th, 2021, so around the month before she saw me, this patient lives up in Ras Al Khaimah. She developed numbness in her toes that reached her pelvis. The right was worse than the left. At that point in time, she did not get steroids. She never had any episodes of numbness, paresthesias, tingling that lasted more than 24 hours. Now, her brother is actually I don't want to go too much and give patient privacy, but her brother is a resident in one of the Saha facilities. So he does have an idea. He's not a neurology resident, but he does have a medical background. So he realized there's something wrong with his sister. And he, at that point in time, made an appointment to see me in the neurology clinic. But prior to this, she never had any episodes lasting more than 24 hours. Her MRI back in June 10th, 2021, when we did it, there's a couple things you can see. You've got on the sagittal images, you can see she has these relatively large Dawson fingers on the bottom left. She also has one GAD-enhancing lesion right there. That's about that one. And she has a lesion at T9. That was based on the report. That was not actually, again, those images, those initial images of her thoracic spine was done in Ras Al Khaimah. So I don't have those lesions or those MRIs. So the MRI report, she has multiple small, well-defined T2 flare hyperintense lesions that are noted. Subcortical deep white matter lesions. She has frontal, parietal, and temporal regions bilaterally. A couple of juxtacortical lesions. She has a left posterior frontal, and she has a lesion in the body of the corpus callosum and in the right middle cerebellar peduncle. When IV GAD was given, some of the lesions were enhancing, and she has a lesion at T9. So now when we escalate this patient, where we look at this patient a little bit further, we have juxtacortical, we have periventricular, we have infratentorial. So she definitely meets all of the McDonald criteria for MS, and she has one GAD-enhancing lesion, and she has a clinical attack. So she has dissemination in space and time. Now, if we look at prognostic factors, she has a lesion in the spinal cord. She also has a lesion in the infratentorial as well. And where was it? Nope, just that spinal cord. And she has an active GAD-enhancing lesion, and she has multiple T2 lesions. And while she improved in her, and while she improved from her initial attack, there was a couple things that came into my mind here. This is a patient that lives in Ras Al Khaimah. I'm sorry. Oh, hi, Habibi. I'm giving a lecture. I have my 2-year-old son who just Habibi passed by. So you may hear a 2-year-old in the background. My apologies. So this is a 1 minute while I pause, and I have a visitor. Even though the door was locked. Okay, well, he's quiet, so I think we can continue. Anyways. Okay, if you can get me, I'm in a meeting. Anyway, sorry about that. So when we look at this patient, there's a couple things. She lives in Ras Al Khaimah. I'm sorry about that, but kids are kids, and you can't control how they move or how they go. They're going to do what they want to do. But anyways, so when we look at this patient, there's a couple things that come into mind. First of all, she lives in Ras Al Khaimah. So she cannot come to SSMC every 6 months to get her IV infusion. That's the first thing. Second thing is, Again, she's a college student. She wants to go to school. She wants an active lifestyle. Number three, we have bad prognostic factors. We have infratentorial lesions. And let me shut the door. Yep, there we go. She has infratentorial lesions. Number four, I want to give this person wants to get married. She wants to have children. And so, she doesn't want to take injections. We know that teriflunomide, Aubagio, is not an option for her. Gilenya, fingolimod, is not an option for her. And ocrelizumab, while yes, some evidence suggests that it may be safe, again, according to the label, you have to wait 6 months depending on the Europeans, or 12 months depending on the Americans, in order to give it to her. So again, probably not the best option. So for this patient, what did we do? I felt that ofatumumab would meet her best quality of life. I'm meeting efficacy, safety, convenience. She has infratentorial lesions. She has active lesions. She can't come. So we did give her ofatumumab on August 2021. And we re-baselined her 6 months later. So these are the old images on the right. Here are the repeat images on the left. And yes, the image does look like a little more atrophied, I guess, on the left, but I think that's just the way the images were cut. But you can see there's two things that come to mind. You look on the left temporal, anterior temporal, you see the small lesion in the anterior temporal that is gone. It's not there, even though it's not cut per cut, that lesion has disappeared. And there's a small lesion right here in the middle cerebellar peduncle. That lesion is no longer there. So when the official report, overall appearance shows improvement as the few small lesions have been completely regressed and few lesions appear smaller, less conspicuous as before. And she still has that T9 lesion in her spinal cord, and there's been no other lesions noted. So we're going to go to case number 3. Case number 3, this is a patient that I saw back in 2017. Back then in 2017, 32-year-old male came, this was back when I was at Mafra. He came to Mafra Neurology Clinic for the first time. He's been previously evaluated for MS at SKMC in 2014. So he was evaluated in 2014, disappears until 2017, sees me in 2017 for the first time. So in 2014, when he was in Australia studying for some courses, I think, in Australia, he developed vision loss in the left eye. Prior to that, he neither had numbness, weakness, tingling, or any other vision problems. He got better after taking a week of steroids. And then in September 2014, he developed Lermite sign. They offered him medication at the time, but he didn't take it. No past medical history, no past surgical history. He works as a detective in Abu Dhabi police. No bladder, no bowel dysfunction, no weakness, no paresthesia. On neurologic exam, his 25-foot walk is relatively fast, 4.51 seconds. Normalish, but still a little slower. For someone this is a physically active person. I would expect him to be a little bit faster, especially because he is a police officer. He has to do physical training at least once a year, the physical exam. And that is a rigorous examination. And so 4.51 seconds in a fit person is probably slow. His examination, 5 out of 5, upper and lower extremities. The only thing that you could argue is a little abnormal is the reflexes in the right knee and the right lower extremities are a little brisk, 3+. And overall, I gave him around 2+ in all his reflexes. And his plantars were downgoing bilaterally. So in April 30th, 2017, this, like I told you, summary, 32-year-old male comes to the neurology clinic at Mafra. In April 30th, 2017, he's here for a follow-up. At that point, I had seen him this is now the second time I had seen him. I was evaluating for MS. He still is not on medications. His exam is relatively normal. His MRI of his brain and C-spine were done, and they were stable compared to previous images at SKMC. And at that point in time, he wanted a medical report to do stem cell therapy in the US. Now I told him, you have no disability, you have a very stable disease. Stem cell therapy is still experimental in 2017. And as Dr. Bassam had showed in his slides, all the people that got stem cell therapy had very active disease. This is not the case. So I told him, really, I'll write the report, but I'm not going to really approve or recommend stem cell therapy. So then he disappears until 2021, January 2021. And so he comes back in January 2021. He's still not on medicine. He had been lost for 4 years, no attacks since then. But the interesting thing is he did an MRI about a month ago at an outside hospital, and he was told there's active disease. The CD was reviewed, and there are 2 new lesions in the brain. At that point in time, patient was told he received, this was back when COVID was kind of still happening. You know, we were in alpha, beta, Omicron, one of the Delta, one of the Greek letters that were popular at the time. But he got his COVID vaccine, he got his first shot, and he was going to take the booster on January 16, 2021. So at that point in time, he now wanted treatment. He now realized, okay, I need to be on treatment. My disease is active, even though clinically he's doing well, but radiographically he's probably not doing as well as he thought. And he's already had 2 attacks back in 2014 when he was on Australia. So again, benign, yes. You know, this is a person that went like 8 years with it relatively. He only had 2 attacks if you consider the Lhermitte with the spinal cord and the optic neuritis. So 2 attacks. So you could say that this is a mild case. But I'll show you his MRI. When you look at his MRI, you see he has a significant lesion burden. You also can appreciate this, the lateral sulci between the lateral sulci or the Sylvian fissure, which separates the temporal lobes from the frontal lobe. It's a little bit widened. This is, you can see in the second image in the middle, and the second image on the left. He has a significant lesion load burden, and he has some atrophy, even though this is a guy with no disability, active, no normal physical exam. You look at this MRI and you're like, this doesn't look like a good MRI. And I think this goes, as Dr. Bassam had suggested, you know, there is always this disconnect between what we see as a patient and we see at the MRI, and we can't always correlate, why does the MRI look so bad and the patient looks so good, or vice versa. And this is partly probably due to the plasticity. But, you know, eventually, and this is and we see this routinely, it's like, usually these patients are good up until the point where that next lesion will make them not good. And they just kind of go over the cliff. And then once they start deteriorating, it's a relatively fast spiral. So the question is, do we wait for the next attack for him to start deteriorating, or do we start treating him aggressively now? You look at his spinal cord, you look at the sagittal, you see he also has a significant amount of perpendicular lesions to his lateral ventricles, typical Dawson fingers. Also, you look at his spinal cord. He has some lesions in his spinal cord. He also has lesions in his brainstem. So this is a person that has infratentorial, spinal cord, brainstem, atrophy, multiple lesions, enhancing lesions. Everything tells you that he's male. He's not 32, now he's like, what, 40? That's still young, I would say, but not like your 19-year-old. So he has a lot of bad prognostic factors. The only thing that's really kind of going to him is he doesn't have any disability from any previous relapse, but he hasn't had a relapse in almost 10 years. But he has active MRI, still suggesting, he has MRI suggesting that he has GAD-enhancing lesions. So this is the MRI report, but multiple bilateral, cerebral, subcortical, deep paraventricular, juxtacortical, all meeting the MS criteria. There's an increase in the number of lesions, particularly in the left high posterior parietal regions compared to the previous scan in 2017. The juxtacortical lesions and the left high posterior parietal regions show edema and incomplete ring enhancement, suggesting active disease. So now, what do you want to choose? You know, just to summarize, he has a large lesion load. He's got brainstem and spinal cord disease. He has at least 2 enhancing lesions. He has atrophy, plus minus. I think he has atrophy, and I hope I proved to you that he has atrophy. And I thought this was increased from 2014. And I think I made the decision or the discussion that he should be on a high efficacy treatment. Now, the other clinics at the time wanted to give him ocrelizumab, ofatumumab. There were questions about Tysabri, but now cladribine, he didn't want to take cladribine actually. There was discussed very briefly. He just, for some reason, he didn't want to take it. So the three treatments that kind of kept going back and forth: Tysabri, ocrelizumab, ofatumumab. Now this person works in police, in Abu Dhabi police, active lifestyle. Even though ocrelizumab is twice a year, he doesn't want to come to the hospital. With Tysabri, he was worried about JCV, seroconversion, and the risk of PML. Even though we never even checked the JC virus, he just didn't even want to entertain that idea. And I tried to explain to him, if you're negative for JCV, your risk of PML in the first 2 years are extremely low, but that was not even something he wanted to entertain. So at that point in time, ofatumumab was the most decent medication that would meet all his expectations, meet his quality of life. He's an active guy, doesn't want to come to the hospital. Again, I'm not sacrificing efficacy for convenience. I'm giving him both convenience and efficacy. And again, I'm giving him something that's relatively safe. Clinic visit on February 2021, he gets his first month of ofatumumab. Again, day 1, day 7, day 14, and day 28. Afterwards, he was verbalized, understood the treatment plan, and was sent home with the idea, you take your medications every month. This was in February. In March, he comes for follow-up. He had just finished his first month of ofatumumab. He had some mild fevers after taking his injection, but overall, he said it wasn't anything serious, did well, took a little bit of Panadol, and no issues, no new symptoms. Now, this slide stops in March 2021. We are now June 2022. His 6-month MRI will actually show stability. Clinically, the patient actually is doing very well. He feels his energy is improved. He feels his cognition, even though he had no significant cognitive deficits, he felt that he's a little bit more sharper. He's still compliant, doing well, no side effects. And I think I made the right decisions for these 3 patients. I hope you guys agree with me. But again, I think this goes to show you why sometimes everybody is somewhat different. What we think should work and what we like to give don't always apply.
Thank you, Dr. Shatila, for this amazing presentation and cases from your real-world clinical practice. And actually, all those 3 emphasize the advantage in some cases of starting patients on high-efficacy DMT and the advantage of induction therapy over escalating therapy. So please allow me to take some questions. So the first question, for the first case, would you think that in such patient with the poor adherence, poor compliance, and low lesion load, do you think then waiting and watching her better than starting her on disease-modifying drug?
You know, that's always an interesting, wait, let me first try to, I'm trying to see the camera on my side. Wait, side by side, gallery. Okay. You know, that's always an interesting question. Should we wait and see? And I mean, I think at some point, maybe 20 years ago, that would have been a nice option. But, you know, in this day and age, you know, let's say, you know, we're going to wait and see. What are you waiting for? You're waiting for this person to relapse. You're waiting for her to actually do bad. You already know she has MS. He meets criteria for MS. So you're just kind of saying, we're waiting for you to do bad. We're waiting for that next relapse, and maybe you're lucky and you do well. Maybe you're not so lucky and you're in a wheelchair. We've all seen that one patient who, after the first relapse, they're in a wheelchair. So the question is it ethically correct to wait and withhold treatment when you know that the treatment is safe, available, and it will work? And, you know, I don't know. I personally don't think it is the wise choice, and the patient didn't want to wait, and so there was no reason to wait. Maybe in other options, maybe if there were insurance issues, Maybe if there were safety issues, the patient was nervous or didn't want to take medicine, we can say, wait, maybe if pregnancy was an issue, we could do that. But if there's no criteria to hold, I would prefer to give treatment unless I have a reason not to give treatment.
Second question, what is the safety of ofatumumab in pregnancy or up in conceiving? So do we need to stop it before conceiving? What is the washout period between the ofatumumab and pregnancy?
You know, that's a very interesting question. And you know, there's two ways to approach this. You've got the label, which says you wait 6 months. But then you have the science. We know that ofatumumab has a half-life of around 17 days. And you guys were probably a lot better at this, but I was always taught 5 to 6 half-lives is what it takes for a drug to get out of your body. So
Yeah.
5 times, let's round it to 20 because it's easier. 5 times 20 is what, 100?
100 days.
100 days. So that's around 4 months minus 20 days. The drug is out of your body by more than 98%, right?
Yeah.
So the drug is out of your body by around 100 days. We know it doesn't cross. We know that immunoglobulins don't cross your placenta until 6 months. So theoretically, you could take ofatumumab. You could take it up until the point you get pregnant, stop the drug the first day of pregnancy, and you're still safe 100 days later, and it's not going to cross the placenta. Now, the FDA says you wait 6 months. But now, if you want to make it more confusing, they say, well, yes, you need to wait 6 months, but you could consider giving it if you wanted to breastfeed. So I think they're being overly cautious, but the science says you should wait. Science doesn't necessarily meet the real life. And I usually I don't tell my patients to get pregnant on it, but at the same time, if someone were to accidentally get pregnant on ofatumumab, I'd feel a lot more comfortable than if they were to get pregnant, let's say, on that versus Gilenya, which we know does have a longer washout, and we do know it is more teratogenic, and it's been shown. That makes me more nervous, or if we have a drug like teriflunomide, where it can stay in the body for 2 years if you don't use the washout.
Another question, one of our attendees is asking about the prognostic factors in MS. So Dr. Yamut tackled this in his presentation, but if you can summarize it again. So what are the bad prognostic factors for an MS patient?
Thank you. I will try to summarize, hopefully. I'll try to get all the key points that Dr. Bassinet said. Being male, bad prognostic factor. Being older, bad. Incomplete recovery from a relapse, it's bad. Motor relapse is bad, then sensory relapse. Oligoclonal bands are bad. And then a high T2 lesion load at baseline, and I think it's 7, is also bad. Did I miss anything? I think I got them all.
Spine lesion.
Infratentorial.
Yeah.
Yes, and infratentorial.
Yeah.
I think I got them all. Maybe there's smoking, bad.
Yeah.
Okay. But I think those are, I think I got them all. Maybe I don't know if I missed one, but those are the bad prognostic factors.
Yeah, smoking, obesity, and the short intervals between relapses are worse prognostic factor. And a final question about, since ofatumumab is an injectable disease-modifying drug, from your experience, what is the rate or the severity of infusion or skin reaction experience? Is it similar to the older injectables, so interferons, for example, and glatiramer acetate?
You know, that's actually an interesting question, because if you know, I didn't really go into the data between the Asclepius 1 and 2 trial, but when you look at the Asclepius trial, which was a double-blind, double-dummy, so in that trial, you had 2 arms, double-blind, double-dummy, meaning that each group of patients were getting an active drug and a placebo drug, and neither patient or observer knew who was getting it, right? Now, interesting enough, the people getting placebo injection had injection site reactions almost as similar as as the active competitor. So yes, you do get initially in the first month, you do get slightly more injection site reactions. They tend to be mild, they're not severe. And by the second month, they're almost the same, whether you're on placebo injection or active injection, they appear to be around the same. And usually the injection is not something people complain about. The first month, most of my patients will complain of this flu-like reaction, especially probably just because it's new, you're getting suppressed, you're suppressing your B cells, and you're taking frequent injections. But after that first month, no one's complaining of either injections or even flu-like reactions. So I would say it's actually better than interferons, because the interferons, the injection site reactions are relatively, you have it for as long as you take it, and the flu-like reactions, if you're not taking paracetamol or ibuprofen, you tend to get it, whether it's on day 1 or on day 1000.
Yeah. Thank you, Dr. Shatila, for an excellent and case discussion and presentation. And with Dr. Shatila, excellent case discussion, second, our session, our virtual clinic comes to its end. Thank you for our esteemed speakers. Thank you, Novartis, for sponsoring this activity. And the big thank you goes for you, our attendees, for staying with us until the end. I would like to remind you that we receive your certificate of attendance by email within 1 week from today. If you missed any part of the webinar or would like to revisit the lectures, you can check our IVPN Neuropsychiatry library, where we post all the recordings. Follow us on our social media platforms and stay tuned for more virtual clinic in June 14 and 22. One will discuss anti-CGRP treatment for migraine, and the other will tackle secondary progressive MS. So keep your eyes on our page, where all the details will be announced very soon. And until we meet again, stay safe. Have a good night.
Thank you, everyone. Good night. And my son
Good
says
night.
good night as well.
Good night. Bye-bye. Bye. 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 Bye.